Good day. Today we are going to talk about benign tumors of the uterus, and it will be in two parts, each for about half an hour or less. And we'll start on the first part of the talk. The benign tumors of the uterus, which we are going to cover, include endometrial polyps, cervical stenosis, uterine fibroids, and Asherman syndrome. And obviously, the main thing will be about the uterine fibroids. So we go to the polyps. The endometrial polyp are epithelial proliferations consisting of vascular, glandular, and connective tissue components. These are the constituents of them. They could be asymptomatic, but may present with abnormal uterine bleeding, either heavy menstrual bleeding, intermenstrual bleeding, or postmenopausal bleeding. And they can have an adverse impact on fertility. So bleeding and fertility effect. The majority of the polyps are benign, but a small minority of them could change and have malignant features. Diagnosing by usually ultrasound, saline infusion sonography, or hysteroscopy. These are the most common sensitive methods for diagnosis, easy diagnosis, and sometimes we use hysteroscopy for the treatment or polypectomy. They are pedunculated or sessile. They could be single or multiple, and they vary in size. So pedunculated or sessile, single or multiple, variable size. The risk factor for the endometrial polyps include obesity, late menopause, the use of tamoxifen, and possibly in some cases of hormone replacement therapy. Removal of it is indicated once it causes a symptom, especially to alleviate abnormal uterine bleeding symptoms and to optimize fertility. And we have to exclude hyperplasia and cancer. That's we're looking at it at the time of removal and also histopathology. Hysteroscopy as an outpatient procedure or in the theater is the method of choice for polypectomy. The second group is the cervical stenosis. It is a pathological narrowing of the endocervical canal, and we take usually the uterus with the cervix. It can be the result of being congenital or acquired. Acquired commonly due to cervical colonization when you are treating cancer of the cervix, especially CIN, where we do LEEP or LITS by doing electrosurgical excision, and also in the cases of dilatation and curettage. It causes secondary amenorrhea, cervical stenosis, hematometria, and an enlarged uterus. So clinically, you will find an enlarged uterus. There is because of hematometria, and there is no bleeding coming externally causing secondary amenorrhea. So it's blockage of the flow of the menstrual blood. Causes cyclical dysmenorrhea with no associated menstrual bleeding. That's to say, the lady gets menses every month. She has the pain, but without menses at the time of the dysmenorrhea. Detected by physical examination and confirmed by ultrasound. Physical examination, you will find a large uterus with the history being told, and you do ultrasound to find it. Treatment includes serial dilatation of the cervix under ultrasound or hysteroscopic guidance so that they won't make unnecessary complications. The next one which will be the main theme of the talk, is the fibroids. We are going to talk about pathogenesis of the fibroid, risks factor, classification or type of the fibroids, clinical presentation, differential diagnosis, complications, obstetric complications, and treatment for the fibroids. This is in general. It will be both part 1 and part 2 of the talk. So let us talk about what do we mean by uterine fibroids or leiomyomas, same name. It is the most common pelvic tumor in women. It is benign, smooth muscle neoplasm. Rarely undergo malignant transformation, about 0.5% of them. So usually they are benign. In a very rare situation, they could go for malignant changes. Most leiomyosarcomas are thought to arrive de novo. That is to say, it is not or there are not complications of the fibroids. The majority of patients are asymptomatic. Majority identified coincidentally. For example, when taking a smear, doing examination, ultrasound investigation, laparoscopic, whether for diagnosis or for sterilization, could be diagnosed there and then. Only about 25% of reproductive age women have symptoms. So the majority are asymptomatic. It is the most common tumor arising from the myometrium of the uterus, composed primarily of the smooth muscles, but may contain fibrous tissue. So mainly it is the smooth muscles. Present in 19 to 40% of women in the reproductive age. 19 to 40% in the reproductive age. More common in those who are nulliparous, women who haven't had any pregnancies before. They can have fibroids, more common also in obese women. If the lady had a family history of fibroids being in the family, in African women, or in places where there is a multi-ethnic and multicultural, it is those of African origin tend to have more fibroids than Caucasian or Hispanic or others. Fibroids are usually multiple and can substantially increase the size of the uterus. Sometimes it may go up to the level of the sternum, being quite a huge fibroid. They result from the monoclonal proliferation of the uterine smooth muscle cells, or less commonly from the smooth muscle cell uterine blood vessels. So it's a proliferation of the smooth muscle cells in the uterus, leading to development of fibroids. The size could range from few millimeters to large tumors, filling the abdomen and pelvis and reaching the costal margin. So it's also important. The fibroid could be small or could be large. When we come to the management, the size has an impact on the management. Tumors may be solitary or multiple. The cell express estrogen synthetase and aromatase and are capable of converting androgens into estrogen. That's to say, it's an estrogen-dependent tumor, if you put it this way. There is genetic predisposition and has been suggested that up to 40% of fibroids have associated chromosomal abnormalities. So besides the ethnic, what we have said about it, there is some genetic predisposition for that. As I have mentioned, they are estrogen dependent. Progesterone may exert an anti-estrogen effect on the growth of the fibroids. So they are more prominent and demonstrate maximal growth during the reproductive years and tend to regress after the menopause. This is very important. During the reproductive life, the fibroids tend to grow. If she goes into the menopause, they tend to regress. And that's when we come to the management also. In the menopause, usually the size becomes less, and sometimes you may leave them alone because the estrogen on which they are dependent is not there. They commonly grow also during pregnancy due to the enhanced uterine blood supply that accompanies pregnancy and the edematous changes in the tissue tumors, as well as the hormone of the pregnancy. Fibroid grow, they risk diminution of blood supply, which leads to a continuum of degenerative changes, including calcium deposition. So as they grow, they may outgrow their blood supply, and the blood supply coming to the fibroid itself may become less. Then a lot of complications or a continuum of a complication starting from different degenerations till calcium formation. And we'll see that in a minute. This continuum of degenerative changes start necrosis, cystic changes, fatty degenerations are manifestations of compromised blood supply, secondary to growth or infarction from torsion of a pedunculated fibroid. So the changes that could occur start from necrosis, cystic changes, fatty degenerations, all are manifestation of reduced blood supply, either as it outgrows its blood supply or if there is torsion. Clinical presentation of fibroids. We have said the risk factors of the fibroids include nulliparity, obesity, family history, and African racial origin. We have already mentioned these are the risk factors. So we come to the classification of the fibroids. How do we classify them? The FIGO classification of the fibroids depends on the location in relation to the uterine wall. So it could be submucous, and you can see it here, submucous fibroid here, where more than 50% projection into the endometrial cavity. This is of the fibroid here. Then the second group is the intramural. And this is the intramural one here, where it is within the myometrium. Submucous here, intramural here. Third group is the subserous fibroid here. 50% of the fibroid mass extends outside the uterine contour or the uterine wall. So all is related to the uterine wall. Other within the uterine wall is called intramural or submucous here, mostly within the cavity or mostly outside, where we call it subserous fibroid. We could also get cervical fibroids occurring here. This is the polyp, it's not the fibroid. The fibroid is here, cervical fibroid. Or we can get them extrauterine, outside the uterine cavity, in different parts, as we will see in a minute. So think about it. Here in this picture, you will see submucous pedunculated fibroid. This is submucous within the cavity and within the myometrium, but here it becomes pedunculated. This is another pedunculated fibroid rising from the wall and becomes pedunculated with a connection that contains its blood supply going there. So these are the different places whereby you can get fibroids. The extrauterine fibroids, as we have mentioned, that are found outside the uterus, usually the result of hematogenous spread of neoplastic smooth muscle cells from the uterus, spread in different parts of the body, are histologically identical to the intrauterine fibroids. So we know them by histology, that it's not a different mass. It is still fibroids composed of the normal histological composition of uterine fibroids. Extrauterine locations most commonly include genitourinary tract, the gut mesentery, and the cardiopulmonary system, where we most commonly do that. Other rarer locations include spinal cord and blood vessels. Have a look at them again. The other group you'd like to be keen about are the pedunculated fibroid. This is an example here. It is mobile, attached to the uterus by a small pedicle containing the blood supply. This is the pedicle that contains the blood supply, and here is the fibroid. Parasitic, when it becomes detached from the uterus and attached to another organ. Broad ligament fibroid that can arise separately from the uterus, presumably from the embryonal remnants. So this is the classification of the fibroid: submucous, intramural, subserous, pedunculated, parasitic, broad ligament fibroids. Obviously, you can get pedunculated fibroid within the uterine cavity and outside the cavity. Another picture of the fibroids, just to see them again. Intramural fibroids, pedunculated fibroids here, and here is the pedunculated submucous fibroid. The submucous fibroid is here. Here it gone beyond the mucosa and becomes pedunculated. This is the subserous fibroids. This is cervical fibroid, and here this is a pedunculated cervical fibroid coming from the cervix, but pedunculated, either coming from the uterus here or from the cervix from here. This is the anatomy of the cervix. The same goes on this side. So clinical presentation. The majority are asymptomatic. Symptoms when they are there include pelvic pressure and pain, dyspareunia, bladder and bowel dysfunction, reproductive dysfunction, subfertility, recurrent pregnancy loss, infertility from mechanical distortion or occlusion of the fallopian tubes. Submucous fibroid can distort the endometrial cavity and prevent implantation, either blockage at the fallopian tubes up or preventing implantation in a submucous fibroid. Abnormal uterine bleeding is the common one, quite usually heavy menstrual bleeding and intermenstrual bleeding. So mostly asymptomatic, but if they have symptoms, they range in this group: pelvic pressure and pain, dyspareunia, bladder and bowel function, reproductive dysfunction and infertility, and abnormal uterine bleeding. Bulk effects on adjacent structures in the pelvis. This is another presenting symptom, not common, but it could present with. Bulk effective symptoms include pressure on adjacent organs and increased abdominal girth. Pressure on the bladder may provoke urinary frequency. Fibroids, if adjacent to the bladder neck and urethra, so incontinence or acute urinary retention with overflow incontinence may occur. That's adjacent to the bladder neck and the urethra. Urinary incontinence or retention with overflow incontinence. Compression of larger fibroids on the lower part of the ureter could lead to urethral obstruction and hydronephrosis. Venous compression may lead to venous thromboembolism. Posterior fibroids may cause constipation, rectal pressure, or tenesmus. So beside the presentations which we have mentioned, there are other presentations related to the position of the fibroid and its bulk effect on the organ to which it is adjacent. If it is adjacent to the pressure causing on the adjacent organs may lead to increased abdominal girth. Pressure on the bladder could lead to urinary frequency, or the bladder, neck, and urethra could lead to retention with overflow incontinence. Pressure on the lower part of the ureter leads to ureteric obstruction and eventually hydronephrosis. Pressure on the limbs, venous compression lead to venous thromboembolism. Posterior fibroids cause constipation, rectal pressure, and enlarged fibroids may often present with back pain and pain radiating down on one or both legs. So this is in short, the clinical presentation of the fibroids. What sort of complications do we get? Let us deal with the obstetric complication. What happens? If a lady conceives with a fibroid, she may miscarriage. She may miscarry. So the end will be miscarriage. She may have preterm labor and delivery. If that didn't happen, she may have failure of engagement of the presenting part or malpresentation, either being malpresentation, breech or transverse or whatever it is, or if it is cephalic, then there is non-engagement. They are likely to be delivered by cesarean delivery, and during cesarean section, the lower segment may be inaccessible, in which situation you may need to do classical lower segment cesarean section the classical segment or classical cesarean section. When we say LSCS means lower segment. Classical in the upper segment. So we have to do an upper segment or classical cesarean section if the lower segment is not accessible. And that may lead to postpartum hemorrhage and peripartum hysterectomy as a result of that. So this is the problem obstetrically. What happens and what sort of complications they can make. Less common obstetric complications include intrauterine growth restriction, abnormal placentation, first trimester bleeding, preterm premature rupture of the membranes, abruption, and labor dystocia, making prolonged labor or difficult labor. So this is why we are concerned with fibroids obstetrically. If they come, they could cause the complications we have mentioned, whether they are common or less common. But still, these are the possible complications one may encounter in a lady with a fibroid. The differential diagnosis of fibroids, it is like any pelvic abdominal mass, has to be diagnosed. First part of it is pregnancy. Pregnancy, usually the abdomen is soft. And the next group is ovarian tumors or a full bladder. The fibroid is usually hard, coming from the pelvis. You cannot insinuate your hand between it and the pubic bone. If you want to push your hand between the fibroids and the pubic bone, it won't do. It won't go. If it's an ovarian mass, possibly the mass will go up into the abdomen and you can put in your hand between the mass and the symphysis pubis or the pubic bone. What sort of investigations, having said that? Simple, we start with CBC because if there is abnormal uterine bleeding, the likelihood of anemia is there. And also when we want to manage it, we have to know. Do urine in general, do an ultrasound to diagnose the fibroids. Ultrasound could be transabdominal or transvaginal, depending on the size of it. If it's a big tumor, you will be able to get it by transabdominal. Sometimes transvaginally, you will see a small fibroid, which is not detected per abdomen. The other investigations we need to do is IVU, intravenous urography. And that's to be done in cases of large fibroids for two reasons. One, we have to exclude hydronephrosis due to pressure of the ureters. As we have said, bulk effects of pressing on the ureter will lead to obstruction and hydronephrosis. So we would like to have an IVU to see whether there is hydronephrosis, hydroureter, and the other reason is also to delineate the course of the ureter for the surgeon. Sometimes when doing myomectomy or doing surgery on fibroids, quite a big fibroid, we'll find that it distorted the normal course of the ureter. And thus you may injure the ureter if you don't see it with an IVU. So sometimes with large fibroids, we make an IVU, put it in the theater, and when you start your surgery, you see the course of the ureter and you would avoid damaging it. Other investigation is hysteroscopy. Submucous fibroid or submucous fibroid polyp will be able to see it on hysteroscopy. MRI rarely needed when the scan is inconclusive. So we do standard test, after that ultrasound, IVU, hysteroscopy, sometimes MRI. Why we do hysteroscopy? Detecting submucous fibroids and endometrial polyps, whether coming an endometrial polyp or endometrial fibroid pedunculated or submucous fibroid, will be able to detect it, and then subsequently we plan how to operate on it, whether it is hysteroscopic surgery or abdominal surgery. And we do hysteroscopy, also operative hysteroscopy. Polyp, we can remove it through the hysteroscope. We use sometimes diagnostic imaging for uterine leiomyomas or fibroids. Imaging, as I have mentioned, includes the pelvic sonogram, transabdominal or transvaginal, useful for detection and evaluation of fibroid growth, distinguishing between a uterine fibroid and an ovarian tumor. So ultrasound here helps, transabdominal or transvaginal. And also we may need to do an MRI, magnetic resistance imaging, evaluating the location of the fibroid and its relationship to the myometrium and uterine serosa, best for surgical planning and before uterine artery embolization. As we will see in a minute, part of the, or one form of management is uterine artery embolization for fibroids. So if you are going to do that, then MRI will be helpful to plan for it. Other imaging, X-ray, hysterosalpingogram to evaluate the contour of the uterine cavity and fallopian tube patency. Sonohysterography using ultrasound instead of radiation characterizes the location and amount of distortion caused by a submucous fibroid and or endometrial polyp. So we can do ultrasound, MRI, X-ray hysterosalpingography, by ultrasound also sonohysterography. So that is the end of part 1, and we stop here for the first part of our talk about tumors of the genital tract.